All right, good afternoon. My name is Ghazanfar Qureshi. I was an advanced interventional fellow at the University Hospitals in Cleveland. Today I'm going to present you a very interesting double valve intervention case. And the objective of this case is to highlight the importance of the comprehensive pre-procedural planning to utilize the CT in a complex double valve intervention to individualize or customize the treatment for extremely high-risk patients. As we know that we see very interesting cases, beautiful results that we get from these structural procedures, but there's a lot of work is behind the scene, which is considered to be a pre-procedural planning. To get to these beautiful results and pristine results, we have to have a good planning to execute. And this case is a perfect example of that. Briefly, the history is this is an 89-year-old very frail lady with previous history of tricuspid valve repair. She had a MACE procedure and a bioprosthetic mitral valve replacement with a Carpentier 29 valve. She's been having a lot of recent hospital admission for the decompensated heart failure. And she was also found to have a severe aortic stenosis along with the structural deterioration of the bioprosthetic valve as suggested by the severe regurgitation. So her STS score was high, more than 10. So these are the images showing to confirm the aortic stenosis, very high gradients, aortic valve area of 0.65, mean gradient of 33 with preserved ejection fraction. And the mitral valve assessment showed, as I said, severe deterioration of the bioprosthetic valve with the eccentric mitral valve regurgitation. So at this moment, having two valves malfunctioning, what would be you guys do at this moment? What would be your approach? This patient should go back to the surgery, have a double valve replacement, or would you prefer to have a transcatheter approach? Any suggestions?
Transcatheter.
All right. So that's what we plan. So this is a high-risk patient, 89-year-old, STS high, double valve. So we decided to go with a transcatheter approach. Okay. All right. So for the transcatheter approach, we always do the CT, right? So that's a CT pre-procedure planning. In the CT, we always look for the axis evaluation, tortuosity, anatomy of the valve, and the valve sizing, all those information. But at the same time, the CT is critical in evaluating further information that it can provide. And as you can see in this image, anybody can tell me what is the problem with this CT image. What's going on in this one? So this patient had a bioprosthetic valve, right? Mitral bioprosthetic valve. So here you can see. So this is a strut that is protruding into the LVOT. And this is the 3D recon image where you can see this is the annulus, this yellow line is the annulus, aortic valve annulus, and this is the white is the protruding bioprosthetic mitral valve strut. And as you can see, the measurements, it is very close to the aortic valve annulus, 2.1 millimeter and 6.8, and the distance from the tip to the septum is barely 3.9 millimeter. So having this kind of anatomy and this complexity, any change in the plans? Would you go for the surgery or still persistent with that transcatheter approach?
Yeah, why don't you tell us? Why don't you go on and tell
All
us
right.
what you did?
So in this kind of situation, there is a third approach. It's called the hybrid approach. So which is basically, it's a comprehensive discussion between the interventional cardiologist and the surgeon. And we decided that we're going to remove that strut that is obstructing in the LVOT along with the leaflet removal. So, and then we're going to have the transcatheter mitral valve in valve and at the same time surgical aortic valve replacement. So the goal for this hybrid approach, which is a non-conventional approach, is to minimize the time on pump that is very high-risk patient would need for the double surgical valve replacement while minimizing the possibility of the catastrophic complication of the LVOT obstruction after mitral valve and valve. As we know that there's a 20 to 30% risk of LVOT obstruction after the TMVR valve and valve. So we proceeded with the surgery, and the surgeon removed that, identified that strut which is obstructing in the LVOT, and he removed the leaflets. At that moment, we deployed the Edwards Sapien through the direct visualization through the left atrium at the mitral valve position, and then after that, the surgeon deployed the surgical valve at the aortic valve position. And these are the images taken during the OR, and as you can see in this panel, this arrow indicates that strut, which is, you can see from the aortic side after the removal, and you can see clearly there's no strut, and then this is the Edwards Sapien valve at the mitral valve position. And this is the intra-op T. You can see beautiful results with the transcatheter mitral valve and valve with no regurgitation. And this is the SAVR aortic valve replacement. Again, beautiful results with no PVL. This is the post-op echo, transthoracic echo showing no LVOT obstruction with a mean gradient of only 6. So the take-home point from this case is to emphasize the utmost importance of the detailed CT pre-procedure planning in this transcatheter valve therapies, which enabled us to customize hybrid approach in this very complex scenario. The two treatments, modalities, surgical and transcatheter, can be utilized together to deliver pristine patient care while preventing potential post-procedure catastrophic complications. Thank you.
Okay, thank you.